Hello and welcome to Thursday Zoom. Miss Marcia's hosting today. Aren't y'all excited? Aren't y'all happy? I'm just kidding. Miss Danielle is awesome. But I want to talk to you guys about something that I'm experiencing in my own career, my other career this week. I want to make sure that you understand that medical billing is not for the faint of heart. It is not for the faint of heart. With my other career, I've had to make a spreadsheet. I'm on my fourth time. There's only 150 patients, and I say only, but when you break that down and how many times we've charged them in line items, it's like 10,847. And I'm having to go through and put notes into every single line item. So the one thing that I want you guys to begin to work on is accuracy and time management. It is so very important. So important. There are things that I love paperwork. I'm the silly girl that loves the paperwork. I usually like the tedious, but not this week. This week I am totally over it. But the work still has to get done, just like your assignments have to get done, right? Whether you want to, whether you're tired. I sat down at my computer at 3 o'clock this morning and started working. It's still not done. When I get off of class, guess what I'm going to do? I'm going to go right back over and start working again because I want it done. I don't want to have to keep getting up every day and saying, oh man. And that's on top of all of my other duties. So I just want to encourage you to get diligent, get focused, and get ready for a career where you're going to be able to I lost my train of thought. Be able to support your family. This is not a job, it's a career. You might start in a job, but you're reaching for a career, right? So you really need to take that into consideration. All right, so we're going to go ahead and get our lecture started. There is going to be a little bit of reading in this one, but just bear with me. I'm just going to do a review on 3 and 4, and we're just going to talk about some of the things you need to know. It's not everything you need to know, but some of the things you need to know. All right, so chapter 3 and 4 in review. Let's talk about confidentiality versus privacy. In your book, this is the very first paragraph that's in your book when you start reading chapter 3. It is important to understand some of the terms. Okay, can we mute, please? It is important to understand some of the terms used in HIPAA. Y'all better say thank you to Miss Danielle because I was going to bring y'all in and do a HIPAA training with you. She said no. She said I couldn't do it.
I said no, because when you go on your job, believe me, they're going to hammer HIPAA in your head enough. You don't need us to do it too.
Right.
Well, HIPAA trainings twice a year, probably.
So anyway, so no HIPAA training. The increased use of electronic technology in healthcare facility, including the electronic health record, EHR, electronic health record, has changed the way patients' confidentiality and privacy are maintained. The terms privacy and confidentiality are often used interchangeably, but in healthcare, specifically in relation to HIPAA, there is a difference. There is a difference. Now that everything from bank card numbers to patient test results are stored electronically, maintaining privacy has become even more difficult. So do you guys want to know how I broke HIPAA just today? I did not bring my screen down in my background for my other computer for my other job. Do you think that would be breaking HIPAA or not?
Yes.
Absolutely, because I had patient information there. Now, right now, can you see it? No, you can't. But that is not the point. The point is, whether you can see it or not, you need to make sure that you're in the habit of minimizing your screen or locking your screen before you leave your EHR open, before you leave any information on your computer where somebody can walk by. You just have to be HIPAA compliant. All right. Confidentiality refers to the duty of all who have access to healthcare information to keep that information private. Those who work in healthcare are ethically and bound to keep the patient's information confidential. Only those people directly involved in the care and treatment of—
There's a thing called stairs.
Can we please, can we mute ourselves, please? Thank you. Only those people directly involved in the care and treatment of the patient should be viewing or receiving this information. So privacy refers to the patient's right to control his or her information. Wait a minute. Privacy refers to the patient's right to control how his or her healthcare information is used and shared with others. Before the information can be disclosed to a third party, what do we have to have?
Patient's permission.
And how do we get patients' permission? A release form, right?
A release form.
The release form. The release form. No release form, no information. Okay? Okay, so both law and ethics require that patients be treated with respect and dignity and be offered the best care we are capable of providing, including protecting all information in the health record. Ethics is a set of rules and standards of conduct that grow out of our shared understanding of right and wrong and that govern our professional behavior. When we formalize, codify these ethical principles and determine criminal or civil penalties for violating them, we call them laws, such as HIPAA. I got a question. When you step into your facility and begin to work, do your personal ethics matter?
No,
No.
Whose ethics matter?
patience.
Patient.
Well, and the person that you're working for, right? The facility.
Right. The
They're going
company.
to give you a
Your
list.
company.
Right. Just for example, if I said I didn't care for Asian people, I'm just pulling that out there, and that goes against my provider's ethics, I got to leave that at the door, don't I? Miss Danielle, can you think of another scenario?
I guess a violation of ethics too can be, let me think.
I'm sorry, I put you on the spot. Can you guys think of something
I'm gonna be
that would be
thinking
against
too.
ethics?
My daughter's being put on the spot for ethics for college. That's what we going through.
Well, I have some good news. In January.
I have one.
Oh, all right, Amanda, share, please.
When I was helping out my sister at her dentist office, there were patients that were coming in, and I wanted to talk to my mom about them, but I knew, because the stories were funny, but I knew that I couldn't give out the name or any kind of information like that. I could just say what had happened and what was funny about it. And my mom kept asking me what their name was and who they were. And I'm like, I can't say it, Mom. It's a HIPAA violation.
Okay, so do you think telling those stories was a HIPAA violation? Or against, yeah, a HIPAA violation?
Yeah,
Why?
because I was telling their personal information.
Okay. Is there any possible way that your mother could know who you were talking about just by the stories?
No.
What do you think, Miss Danielle?
I mean, I I don't see where there's really a violation
It's
because
not.
you didn't use names. As long as you know you're not using names, you could be talking about anybody, but you do want to be careful in where you're stating that because especially if you're repeating it in the clinic and the patient still happens to be there, then we can fall into, looking at something a little bit different as far as like the HIPAA violation because that patient is still there and she may overhear you actually saying what happened, even though you're not giving any names.
Right.
So
I think you're more shaky on the ethical grounds rather than, well, and I say that it like if you were gossiping, that's probably not great ethically. Or if it was just a little funny story that you shared with somebody you were in the office with and it was, then I think that would be okay. But as long as your mother couldn't identify who those people were, HIPAA wise, you were all right. So say that a man comes in with a tattoo.
Sorry.
No, well, he comes in with a big tattoo, like on his neck, and it's a dragon. Dragon, the head goes up. And all of a sudden, you start telling somebody about the story about this man with the dragon tattoo. What do you think? Is that HIPAA?
Yes.
Yes.
Me,
It can be
yes.
identified.
It can be identified. All right, I have one more scenario for you. So a mama needs her kids' vaccination records and she has to have them for the next day for school, but she doesn't get off at 5 and your clinic closes at 4:30. Can you put that vaccination record in the mailbox outside so she can get it?
No.
No.
I had a student of mine do that and called and told me about it. And I was like, do we need to go back to HIPAA class? She's like, as soon as she said, that's why I was calling you. I had to call and tell you I did a boo-boo because I knew better. I said, that's absolutely right. She said, but the office manager told me to. I said, then you let the office manager carry whatever she wants out that office, but you do not. You follow the HIPAA laws. Don't do it again. So anyway, all right, so let's go back to our slides. We're going to do a critical thinking exercise. All right, remember, let's just take a seat back and we're gonna do this in a way that's very organized for class. Do you agree with the idea that it is human nature to show a preference at times for those we like or have something in common with, and to occasionally be less attentive to those we find disagreeable or who are least like us? If so, what can we do as ethical healthcare professionals to treat patients equitably? Or do you think it's all right to show a preference? Now, this is a hard one, right?
I love this question.
That's why it's in here, because I think that let's just stop and think about how we interact with our friends and family. There's some family members that you don't particularly care for their personality, so you're at a function together. How many of you are going to be polite to them? I would, just because that's who I am. Brittany is not. Yeah, Brittany.
It's
no.
in my nature to be nice.
It's my nature to be nice too. I can think whatever I want as long as I'm not putting that attitude out. So same things with patients. You may have a patient that comes in that never bathes. You better hold your breath or get you some Noxzema and put under your nose or something. But you cannot treat him differently than the lady that's walking in behind him that's dressed in gold. How do you say it? Dolce and Gabbana? Dolce and Gabbana. And her diamond rings and all this smelling good stuff, and she's just, dressed to the nines. You can't treat them differently. You have
Now,
No, you can't.
Martha, being that you said that, I have a little bit of a story that I want to share with you guys, that something that happened to me when I was working in a clinic. Again, I'm not going to say anybody's names, but this was very tricky and this was really hard. So we had a patient that came in every month, and she had a lot of cats. Like, she would come to us and tell us she had taken in stray cats from everywhere, and then the stray cats had babies. At one point in time, she probably had about 65 or 70 cats living in the house with her. So when she would come in, she literally, I don't know if anybody knows how cat urine smells. It is like really strong. It's almost like turpentine. It's like she would walk into the door and the entire office would just reek. The patients were nauseated. Some of them said that their nose was burning. So when this happened, we're kind of in a huddle, like, what do we do? Do we go and tell her that, the smell that's coming from her is causing some of the other patients to feel uncomfortable? And we ended up, it went on for a while. It went on for probably about 2 or 3 months. And finally, I was the office manager. So I had to pull her to the side. This is what the physician told me to do, though. Pull her to the side and just have a conversation with her. And maybe suggest that she sit in the car until it's time for her appointment, and I would come and get her and bring her in because of the smell. And it had nothing to do with us, because as professionals, we have to learn, like Ms. Marsha said, to, suck it up. But it came to a point to where it was affecting the other patients that was in the waiting room. And that's when it came to the point to where we had to make a decision about what we were going to do and how we were going to handle this ethically and still not make her feel uncomfortable. So I did have a conversation with her, and I was very gentle in the way that I told it to her. And after that conversation, she tried really hard every time she came in to make sure that, because what was going on, the cats were peeing on her clothes. And I guess she was letting it dry. I don't know, but she made an effort to make sure that her clothes were clean and free of any type of scent before she came. So when she would come to the office, she would come to the desk and she would ask for me, and she asked me to smell her and tell her what I smelled. And every time she's like, I want you to be honest. And I was honest, and it got better every single time. Every visit I seen her, it got better and it got better and it got better. So that was a tricky one for ethics. Just in case you guys run into a situation like that, that was something that I had to do while I was in an office. It was very, very tricky, and it was a hard situation to actually maneuver through. Tracy, I see your hand.
Oh no, I'm just gagging.
Are you?
I'm sorry. I know the smell you're talking about. That's why I'm like, ew.
Yeah. So that was my story, y'all. That was my ethical moment in time. Would anybody else have handled that differently? I see Ms. Marsha, you're muted. I don't know if you were talking.
Yeah, I unmuted myself. I was just gonna, have anything to add or anything that you'd like to share?
Anything would you guys have handled that differently, or?
Would you be able to ask the doctor to be able to talk to the patient about it?
See, doctors hire office managers for a reason. Doctors hire office managers so they don't have to handle things like that. They do not handle money. If you come in and you can't pay your copay, or you're causing issues in the front office, this is why they hire office managers. They do not deal with any of the nonsense.
I always said, like, your health's at risk. We need to talk, lady.
Well,
The doctors do not, they don't play. That's the easiest way I can put it.
Even at Oshner.
Because when I worked with Dr. Gutierrez and the other doctor that was there, Dr. Gutierrez would come in exactly when it was time for him to start seeing his patients. He would see them, and then as soon as he was done seeing them, he was gone out that door. You couldn't ask him any questions once he walked out that door.
That's why he hired all of y'all. He didn't want to deal with a mess. Didn't want to deal with the mess. All right, so now we're going to go to chapter 4, and we're going to be talking about medical office assistants roles in the medical office. Okay, first of all, I want to make something very, very, very clear. You will be medical office assistants, not MAs, medical assistant. There's a word there, which is office. You always want to be within your scope of practice. So say I'm an MOA in the front office and my doctor comes and says, "Hey, I need you to give so-and-so a shot. We're short-staffed." That is out of my scope of practice. Doing blood pressure and all of that for myself personally is out of my scope of practice. Now, if you willingly go into training to learn how to do those things, then it can be within your scope. But if you do not feel comfortable, then you need to let your provider know, I need training on this if this is a duty that you want to add to my duty list. Because you always want to be within your scope of practice. So now that that's out of the way, let's get back to this. The role of the front office assistant: maintain scheduling, creating the patient record and managing an electronic health record for each patient, generating patient letters and other correspondence, providing patients with registration forms and other required documents such as notice of privacy practices. You're going to be answering the phone a lot, right? So let's talk about common types of telephone calls. There's going to be appointment requests, inquiries from prospective patients about the practice, requests for medical advice from a physician or nurse. Prescription refills is probably one of the top ones, that and appointment requests. Insurance and billing questions from patients, information requests from insurance companies, questions from pharmacists, medical supplies vendors, and other medical offices. Now, I guess I'm going back and forth a lot because I have a lot to say to you today. You ever heard the saying, you can catch more flies with honey than you can vinegar?
Yep.
Yeah.
Lots of times I don't have as many troubles with rude patients because I'm so nice that I give you a toothache. Do I feel that nice? No. Am I always this bubbly? No. It's just my knee-jerk reaction. It's how I was raised. It's how I present. You can ask Miss Danielle. I'm like this all the time. I'm bubbly and happy all the time. Well, there's times when I'm not, but y'all will never see that. So when you're answering the phone, how do you think you should answer the phone? Hello, this is Washington Clinic. How can I help you? Or, hello, this is Marcia. Thank you for calling Washington Clinic. How can I help you today? Obviously, duh, right, Tracy? I know. Look, you're gonna have to work on it, sister. It's all.
Girl, I own a bakery. I know exactly what you thought about.
You can do some customer service. It's
You think I like it?
all about customer service. Patients are your customers. Without patients, you don't get paid, right? And one of the,
I'm sorry, Ms. Marsha, I'm gonna go a little bit further. Like, you know, our MOAs in the front that sometimes assist in the front with answering phones and stuff like that. You definitely will always want to be that upbeat, bubbly type of personality. That's actually the type of people that they hire for those positions in the front. But I'm hoping that all of our billers at one time go into management, because in most offices, billers are managers most of the time. Most billers are managers in the back. And this was when you have to kind of, I'm not going to say put the bubbly hat to the side, because we definitely never want to do that. We always want to come across as a pleasant person. But at that time, that professionalism hat has to be pinned on tight on your head. And professionalism has they have no frowns. It has no smiles. It has no, I don't know how you put it. It has no exterior
Personality.
feel to it. It is beige. It has no color to it, because you are simply now the person that's there to follow policy and procedure. And I've been in positions before where patients came in and they were very upset about different things, and I kept a even tone, even keel throughout the conversation, whether I was talking to this person about being upset or I was talking to this person about their granddaughter turning 2. It was always even keel because I never wanted anybody to understand or hearing my voice when I was upset or when I was sad or when any type of emotion that I was feeling in those conversations, because at that point in time, I'm not there to feel emotions. I'm there to make sure policy and procedures are being followed across the board. So MOAs in the front, definitely we want to maintain bubbly personalities and be, you know, smiling. But our future managers, our billers that's going to be in the back, remember to keep them professional hats on at all times. Keep your professionalism at front and center at all time. We almost kind of gotta be kind of like robotic. They won't know how you're feeling.
Well, and can you guys believe that I struggle with that?
I don't.
Because, well, and look, I'm a honey darling, come on, let's fix it, good old girl. That's just who I am. But sometimes I have to kind of put that at the back of my mind, and I have to tell them how the cow ate the cabbage. No, I'm sorry, that is the correct NPI, and you do need to reprocess this claim, and you're not going to tell me that you cannot do that. If you cannot personally do that, then I need to speak to your manager right away. He's not available, then you find one that is available. Do not hang up this phone. You get me what I need. So we're talking to insurance and we're talking to people that are trying to get away with not paying you. You got to have that hard, not really hard personality, professional personality. You have to go into it like, I know what I'm talking about. Yes, ma'am, Amanda.
It's like when you work the front. My sister, she would always be polite, but she was polite and respectful to that patient, but yet stern at the same time. You have to find that mix that just works for you.
Right. Okay, so here we go. Let's get on with it. So today we're actually going to do something in sim charting. Now, I know that we have some that are still struggling to get into sim charting. And again, be patient. Let me or Miss Danielle know if you can't get in, and we will advise you. But Amanda, I don't want y'all to be stressed. Nobody gets stressed. We're going to get there. That's why we start a month in advance. So we're going to get there. So once you can get into your sim charting, launch it. And the only thing that we're going to look at today is the form repository. So in your EHR system, you're going to have tabs built in. If you look at the top, there's calendar, correspondence, patient demographics, find a patient. We're going to look at form repository. And I think we looked at a little bit about this when I first introduced it. But I want to show you the patient's Bill of Rights. The patient has rights, and they will be given a copy of their rights, and they actually sign one to go into the chart. I'm not going to read this whole document because I've read to y'all enough today. But I want you to get in, if you can get into your sim charting, get in and look at this form repository. Find out what's there. Let's see, I'm looking for something specific. Office forms. Notice of privacy practices. Man, if it would have been a snake, it would have bitten me. This notice of privacy practices, all about your privacy. So this is what the patient is given to read and to sign, and these are the expectations that you are held to for your patients. So take time to read through that and look at it so you absolutely know what you're going into. It may be a little bit different when you get into your facilities, but I think pretty much they're about the same thing. Your medical release form. We talked a lot about that. Can't get medical records unless you sign a release form, right? Anything else on here, Miss Danielle, that you think we need to take a look at?
I see there's a prior authorization request form there.
Oh, do you want to talk about prior authorizations for the end of our lecture today, Miss Danielle?
Sure, I can.
So let me, and you can tell them, what is a prior authorization? Does anybody know?
Does that have to do with insurance?
It absolutely does have to do with insurance.
Yeah. There's actually positions out here that hire just for prior authorizations because it's become, over the years, prior authorization has become something really big. Whereas when I remember first starting, prior authorization was kind of almost non-existent. The reason why they are so prominent right now is because we have so many procedures and different things that we're getting done when we make appointments. So physicians want kind of I won't say that it's a guarantee to pay because you'll hear that often every time you do a prior authorization, they're going to first of all tell you that this is not a guarantee of payment. But in so many ways it is, because if it's billed correctly, if it's coded out correctly and that prior authorization was approved, they're going to pay it. The reason why they're going to tell you that it's not a guarantee of payment because you as the biller could actually bill it incorrectly. It's not actually not paying because the authorization was not approved, but it's not paying because maybe something was going on with the billing. But prior authorization essentially lets the physician know that I have already asked the insurance company, if I bill this, will you pay it? That's basically what prior authorization is. If I see my patient for this procedure, will this policy cover this procedure? And if it will not cover this procedure, I want to break down what the patient's responsibility is going to be for the procedure. Like for instance, even with dental offices, you might go and get a root canal prior to them actually telling you, you know, okay, we're going to do your root canal on such and such day. They're going to come back and they're going to give you an insurance breakdown, and they're going to tell you, well, we've contacted your insurance and we've requested for these services to be paid, and this is what they said. So they said that you are going to be responsible for $2,500. They're going to cover the other $1,500 that the procedure cost. So essentially, authorizations just lets the physician know that the insurance is going to render the funds for the services that they are requesting, in a nutshell. There are some, like I said, most of the time if you're working for like maybe a physician that does surgery, sometimes prior authorizations, a lot of PAs now for medication, because medications is so expensive right now. We have a lot of different pharmaceutical companies that make pretty much the exact same drug. So if a medication is extremely high, when you drop that prescription off at the pharmacy, the pharmacy is going to say, oh, this needs a PA. I was actually talking to my mom the other day because she needed some medicine for my little brother, and she paid cash for it, and I kind of fussed at her because what they don't tell us about prior authorizations for ourselves is that we don't even need the doctor to actually complete some of them. I'm not going to say all of them, but some of them we can actually do ourselves, because this is just a series of questions. They're going to ask you 7 different questions about you and things that you're going to know. What type of medications are you on? How are you diagnosed with this? Are you diagnosed with that? How long have you been on medication for this? You know, it's just a series of questions. So in some instances, we're able to get our own prior authorizations done for our medication, and we don't actually have to wait for the physician to do it, which can sometimes take 2 or 3 days for them to actually get to it. Not in all instances, because sometimes when it's a medical procedure that needs to be done, the physician is going to have to do it because it's going to entail some medical questions, such as the type of tools they're going to be using towards the procedure, or what is the prognosis and the diagnosis, you know, and all of that good stuff. So PA in a nutshell.
All right, and I'm going to show you guys something really quickly. So, does anybody recognize this? Some of us have been over it, some of us have not. This is a claim form. This is in essence where all of your information goes when you're going to bill. I just want to show you line 23 right here. This is where you're going to put your prior authorization number in.
And if you happen to bill without that prior authorization number on a claim that a PA was actually approved for, what do you think happens?
They reject it.
They deny it. Yep. PA missing from the claim.
And so you got to go back and find the PA, submit a corrected claim with that number in it, and wait even longer for your claim to be paid. So yeah, that's prior authorization. Did I tell you guys that I'm going to be hosting a NCCT review class, and it's going to start January the 16th? And it's going to be laws and ethics. In all classes, all students are going to be invited. So we will be sending a flyer out for that in at the beginning of January. You guys know we have a 2-week vacation coming up, right? Miss Marcia's class, I'm off next week. I have a 3-week vacation just from Unitech. Just from Unitech. I have a 3-week vacation. But you guys know that you can still text me. I know that I told that I said I wasn't going to answer it. I can't do that. I just absolutely can't do it. I probably won't answer email. So if you need something, just text me so I can text you back real quick. Okay. Also, it's very, very important. Next Friday, you will have a very important video to watch. And I will answer any questions after that is released to you. But it's good news. It's fun news. All right. Does anybody have any questions?
Miss Danielle, I'm behind on my assignments. So if you could just kind of keep them open for me, I would appreciate it.
I got you. You stay on for me too. Miss Marcia, can Amanda and I use your Zoom for a couple seconds after we get off?
Absolutely. I just have to stay. I'll
What's the dates for the break? What are the dates?
let's
December
see.
25th to January 8th.
Same days as my kids. We good to go. All right.
January 8th. So
Yeah.
I will still be hosting live lecture on next week, right before our break. So I'll go over some things going into our break that you guys are going to be expecting to see. I'll go over that next week and we'll chit chat
Right.
about it.
And listen, do not make me come find you after your 2 weeks off. I'm serious. Do
2
not
weeks
get
is
out of
long
the
enough, you guys. Do not try to extend that 2 weeks to 3 weeks to 4 weeks. 2 weeks is a long time. 2 weeks is enough time for you to get refreshed, revived, going into a new year, and even more hyper focused than you are right now. It's the
I'm
beginning of the year.
probably going to be sad that I'm not doing schoolwork.
I can give you some stuff to do now.
I'll give you my kids. You can have it for 2 weeks. I'm going. Bye.
I got 3 kids myself, plus an extra one who's 15 years old. So I'm good.
A quick
I say the same
question.
thing. I'm gonna be home and don't have nothing to do. You can send me some schoolwork to do.
Me
Yeah,
too. I'm
hey,
going.
I have my very own YouTube channel. You just got to look for Miss Marcia's YouTube. Well, I don't know what it is, honestly. I didn't even know that I could read comments on there until I accidentally ran across it the other day. But yeah, get on. Look, pull out your manuals, your coding manuals. Oh my gosh, I can't talk anymore today. Pull out your coding manuals, play in them. Contempo Coding on YouTube. I love her. Watch Contempo Coding.
Yep, code with her. She's going to give you step-by-steps on what to do.
And so when it comes time to code, which is going to be a little bit, thank goodness, because I was so sick of it by the time we got finished with it. And we all feel like that. Once we're done coding, we're like, thank you, Jesus. It's over.
Yes. Oh yeah. So for our new students that are just coming in and hasn't gotten a chance to even go over coding, if we want something to do over our break and we absolutely have to have something to do, I would say take some time and familiarize yourself with ICD-10 and CPT coding, because we're going to get into it. And if you take the time now to just basically just get familiar with the gist of it, just how it works and what it is, once we get into it, you won't feel as like, what in the world is this? Because everybody does, and you will too. But I will go ahead and bite that bullet now and just become familiar with it. So I'm not in shock. I don't like surprises. So I normally research everything that I can research before I even get to it. That's just me. I don't like to be surprised about things.
Be proactive in your education, folks. Senior students, you want to go back and get back into your workbook. Start coding the things that you didn't get done in your workbook. Do your exercises. Anyway,
Work on your NCCT practice exams. If you haven't purchased them yet, go on ncct.com and purchase your practice exams and do some practice runs on your NCCT website. So
Yeah.
yeah, we can give you tons of stuff to do.
so I am going to tell you Merry Christmas and Happy New Year because I won't see you guys again until I get back.
Merry Christmas.
Merry Christmas and
Merry
Happy
Christmas
New
and Happy New
Year.
Year.
Don't be shocked if Thursday you don't see my face up in here anyway. Because
Drink some for me.
huh? What'd you say? What for you?
Drink some for me. Drink some for me.
I ain't gonna talk about that. Anyway. All right, Miss Danielle, nothing else? Nothing else? Anybody else?
Nothing else. I'm just gonna grab Amanda for a couple seconds.
Okay, before you guys pop off, I want to say thank you for coming and spending some time with us. This is our favorite time of the week. This is where we draw our inspiration from. It's just being with you guys. Because I don't know about y'all, but it's hard to have a conversation with just a computer. We need people on the other end. So
I have a quick question, Miss Marsha.
sure.
One of the EHR exercises, when I went to do it, the patient was not in.
Was there
Patient
was there
search.
a EHR exercise in your assignment?
No.
Okay, so this is what I want you to do. I want you to go to chapter 2, go to the very end of your chapter.
I did that.
And you put those demographics in for those 3 patients. Well, then you're just gonna have to wait, sister.
Look at her working ahead of time. I was just about to
She
say,
wants to pick it up and run with it.
she is running, sound like it. From what I hear, she's running already.
Yep, she is. All right, well,
Alright.
everybody may leave except for Amanda and Miss Danielle.
Y'all have a
Talk to you
good rest
guys
of your
later.
day. Have a
Bye,
good
guys.
weekend, y'all.
Bye.
Y'all have a good one.